Good morning. My name is Curtis Thompson, one of the dermatopathologists at CTA Pathology. And today I'm going to be giving you the next in our series of the Lever Derm Path lectures. So we're on chapter 14, non-infectious granulomatous reactions. And I'm having them email out the lecture notes that I prepared. And I will cover pretty much everything on these notes. They're very cursory. So I distilled down the subject to 2 pages on a Word document, and I tried to put things in there that I think are big concepts, some detail for your board exams, and then and so hopefully this will be useful for you. Also, I'm not going to do unknowns from this chapter. So the plan is at the last lecture, pretty much of every month, one of us will do an unknown session with unknowns from the chapters that have been covered in the prior month. And then once again, we're trying to cover the entire subject over 10, 11 months. And then we'll do board unknowns at the end of the May, June, at the end of the year. So to begin with, just FYI, this may seem a little, if you're reading the Lever book, I prefer the Whedon book, but it's really a difficult book for students to get their, it's so voluminous that I have prepared this lecture on the subject, mostly using the Whedon book, but with reference to Lever. And so you might see some differences here. So when we're talking about non-infectious granulomatous reactions, I need to just pause at the beginning and say 90% of granulomas in some countries are infectious in origin. So it depends on where you are, so the smaller set of non-infectious granulomatous reactions are what we're going to talk about. The Lever chapter talks about palisaded neutrophilic and granulomatous dermatitis. I've seen over my career, this is kind of became an entity, then became a pattern. And I think it's best to view it as an inflammatory pattern. And one concept, which I'm going to repeat again, is neutrophilic, an infiltrative neutrophils, which we call can also call suppurative. So when you say the word suppurative and granulomatous, at the same time, you should immediately think of an infectious process. So this is palisaded, so it's a little bit different, but we're going to look at a lot of palisaded entities today. So further definitions, let me start into this. A granuloma, so we want to talk about granulomas, giant cells, and granulomatous dermatitis. And I just want to spend a little bit of time on the semantics so we can communicate better. So a granuloma is a collection of histiocytes, and it may not actually have giant cells in it. So you can have well-formed sarcoidal granulomas, collection of histiocytes, and never see a giant cell in them. And then here you can see subtyping of giant cells. And this is just one general classification where they've been classified giant cells associated with tumors and giant cells associated with inflammation. And that's somewhat useful, like the Reed-Sternberg cells. You have the owli, double nuclei. You can have tumor giant cells in many types of tumor, melanoma. You can have it even in basal cell, rarely. And then osteoclastic means it just looks like a normal osteoclast, the bone resorbing cells normally that we see in bone, but you can see them in tumors. That being said, these can also show up in inflammatory processes. So for the purposes of today, and for us, oh wait, this is the osteoclastic. And I just want you to kind of memorize this look. It's a cluster of nuclei here. And then it has this ground glass appearance to the cytoplasm around there. And this can be seen in foreign body giant cell reactions, and even in sarcoidosis. So you can't be, one of the concepts here is you can see these different types of giant cells in different processes, and they may be clues to a certain pattern, a certain diagnosis, but you can't be too concrete about it. So for us, the ones we want to really focus on are the foreign body type, which we'll see more of these reactions to exogenous material or to endogenous foreign material, like usually extravasated keratin. Langerhans giant cells, which aren't really always a ring, they can be arranged differently. We'll talk about that. I mean, Langerhans giant cells, sorry. And then Teuton giant cells, where you have the ring of nuclei and then foamy outside it. So these are the some of the tools we're going to work with. So types of granulomatous dermatitis, these are the ones that serve us, and we'll talk about sarcoidal pattern. So a sarcoidal pattern doesn't necessarily mean it's sarcoidosis, and we'll get into that. Tuberculoid looks like what the granulomatous reaction you see with tuberculosis, but that also may not represent tuberculosis. Necrobiotic, which is a term that Bernie Ackerman really did not like. He didn't believe that it was true necrosis, but it just means degenerated material. And we see this in the center of a lot of granulomas. The foreign body, which we've already mentioned. Xanthogranuloma, which is foamy. So when we say xanthomatous without the granuloma, we're saying we're not seeing giant cells. And we append the granuloma to it, we're seeing giant cells with them. So, and you can, we talk about juvenile xanthogranuloma and the actual, what we consider a neoplasm, but you can also see foamy cells in different processes. And then suppurative, implying infectious. So here's different types. Here you can see, here are foreign body type of giant cells around a foreign material. This may be endogenous, I'm not exactly sure. This is a foreign body type giant cell reaction. And then here you can see the ring of nuclei with foam around it. So that's a Teuton. So this is the xanthogranulomatous pattern. And then here you can see a fairly well-formed granuloma with surrounding lymphocytes. So the lymphocytes are present a little bit in the granulomas, but not much. And this is the term naked granulomas that we associated with the sarcoidal pattern. Tuberculoid can be variable. You can have true necrosis in it, variable amounts of neutrophils, and often implies an infectious pattern. Here's suppurative. So suppurative and granulomatous, which I said is a infectious pattern. And then this is the so-called necrobiotic. So we see macrophages here between the collagen bundles palisading around this acellular area where we see blue staining mucinous material. So that's exactly what these are. So one concept here is different granulomatous. So different etiologies can have one pattern. So this is the sarcoidal pattern, the naked granulomas. We don't see very many lymphocytes within these well-formed granulomas. This could be infectious. This could be tuberculosis. So it's a sarcoidal pattern, but it doesn't mean that it's sarcoidosis. So in sarcoidosis, we talk about these naked granulomas I just mentioned, and know that any type of giant cell may be seen. So you may, we don't really assign one of these giant cell types to sarcoidosis, and it's not uncommon to not see very many giant cells. So important to remember that sarcoidosis is a diagnosis of exclusion. So you have to rule out infection, AFB fungal, using special stains, culture, and now PCR is becoming more and more important. No polarizable material. Now that being said, if a patient has sarcoidosis and they have foreign body somewhere on them, like a tattoo or something, the sarcoidosis can present in the where the foreign body is, and so this can be confusing. And then the diagnosis is made with the standard lab test, generally the ACE, increased ACE. So other things in this diagnosis of exclusion, you have to rule out Blau syndrome, which this is board material, NOD card 15 gene, make sure patients don't have Crohn's, oral facial granulomatosis, I'll mention later, rheumatoid arthritis, a reaction to TNF alpha inhibitors, And rarely lymphoma. We talk about the granulomatous slack skin in mycosis fungoides is very, very rare and generally is not a problem in making this diagnosis. And then back to infections, just always mycobacterium. And then know that post-zoster herpetic dermatitis can be granulomatous. A couple of features that are associated with sarcoidosis but not specific is this exogenous or degenerated material, and this is what you need to know for your boards. This is called an asteroid body. They're pretty little star-like crystalline material that's inside a giant cell. Once again, not specific for sarcoid, but when we say asteroid bodies, we tend to think sarcoid. We see it more in that. And then Schaumann or conchoidal body, same thing, has mineralized calcified material. And then you'll often see it in layers. So you'll see dark and then a clear, and it can be even bigger than this. And here's a foreign body giant cell. So we have a reaction to this material. Once again, not specific for sarcoidosis. So a few other details about sarcoidosis. Know the term, lupus pernio. When I trained, when we said lupus pernio, we thought it was lupus vulgaris, tuberculosis involving the nose, cheeks, and ears. But I think the current thought is that it's almost always sarcoidosis. So lupus pernio is just a granulomatous process on the nose, cheek, and ears. It's a very confusing term because lupus, it actually comes from wolf. And then perniosis, it's not, we're not talking digits here. So this is you have to be careful using this term, but in general, it means sarcoidosis present in this pattern. And once again, you still have to rule out other things. Erythema nodosum, I think it's important not to think of it as a disease unto itself. So it's a pattern. So it's subcutaneous granulomatous process, mostly in the septi and in the lower legs. But know that up to 25% of patients with sarcoidosis will develop these lesions. 3 to 25% is what the book said. But I think if you follow these erythema nodosum patients out, a certain percentage of them will end up being infectious, a certain percent will end up being sarcoid, and a certain percent may end up even being vasculitis. So I view this as a pattern, but not a disease unto itself. Subcutaneous sarcoidosis, which is quite rare, is more associated with systemic involvement. And then these terms can be confusing. The use of the term orofacial granulomatosis was an attempt to join these entities, the Melkerson-Rosenthal and granulomatous cheilitis, into one entity. And so it's just important to remember it's the triad. So we have sarcoidal granulomatous process around the mouth. So you biopsy it, you get the granulomas. We have the orofacial nerve palsy, fissured tongue, the lingua plicata, and then the granulomatous. This granulomatous could be a reaction to a foreign body, like a food, maybe metal in the mouth, could be an infection too. So once again, this is like more associated with sarcoidosis, but could have other causes causing this granulomatous process. Whedon points out that there's been a publication that says in sarcoidosis, 62% of the biopsies will show a perineural granuloma, which can make this more confusing. And then for boards, know this, the GLI1 oncogene homolog, we know that it's associated sarcoidosis, granuloma annulare, necrobiosis lipoidica, and this is one of the reasons we use the tacrolimus or sisalimus in treatment. So another big concept here, this is a very old concept, but it's red and blue granuloma, so really appropriate given the events of this week. But the blue granuloma is what we think of with granuloma annulare. Yeah, and the red granuloma is rheumatoid nodule. But you can see if we didn't have the color, how they almost look identical. So they have the degenerated necrobiotic material in the middle. They have the macrophages going around the edges. And then in here, this is pink staining, and here this is blue staining. This may be a mucin stain, but you will even see it on the H&Es. So this is actually a issue you run into when you do get biopsies, because granuloma annulare may be near joints, and rheumatoid nodule almost always near joints. But here we have granuloma annulare. Wegener's can have this pattern, and then we say rheumatoid nodule over here, Church, Strauss, and Whedon lists necrobiosis lipoidica as having the red center when it has palisaded inflammation. So moving on, granuloma annulare, it's my favorite term in all of dermatology because it fits the histology, granuloma, and it fits the clinical. Lesions are often annular. So we have such terrible names with mycosis fungoides, but granuloma annulare wins. There's many associations with granuloma annulare, and basically, I guess the board question is it's been associated with everything. So there's reports of it, but it's hard to really understand this because it's so common. So it's not uncommon for us to see incidental biopsies of granuloma annulare. And I actually had a case a couple of years ago where the patient was thought to have lupus, got a biopsy, got histologically perfect granuloma annulare, and they started light treatment. Patient got worse, and it actually was just an incidental GA in a patient with lupus. So the patient did have lupus. So ways we divide this up, there's localized and generalized, and the generalized has a little bit different histology. Often looks a little more like lichenitidis with superficial lymphocytes and some macrophages up near the epidermis. And then you can have deep GA, and this is one like I just showed you where the deep GA might have more of an appearance of a rheumatoid nodule. Females much more than males. One of the board questions, HLA-BW35. And the whole interstitial granulomatous drug, which we'll mention at the end, can have this histologic pattern. So it just kind of falls back to say GA could have a drug etiology. So Whedon describes 3 patterns, and I snapped this out of the Lever book, but the interstitial or incomplete, that's the same term, but it's not a terrible term because it is interstitial, and incomplete is meaning it never got to make a nice palisaded granuloma here. And this is the most common pattern that we see. You can find EOs in it, no plasma cells, and when you do a mucin stain, it'll light up this area right where there's increased cellularity. This is a low power diagnosis, and you just back off and you can see these areas of increased cellularity, which can be at any level of the epidermis. So the necrobiotic is this, where you have the degenerated material in the center. These are kind of the same, and you can see here's degenerated cells. We don't know that these are necessarily neutrophils, this material here. We always assume because neutrophils fall apart so easily, but these infiltrates generally aren't marked with a lot of neutrophils in them. You can see them, so you can't be too concrete about it. And then the last pattern that Whedon describes is sarcoidal or tuberculoid. So I don't have a picture of that right here, but it's one with just a much well-formed granuloma. The sarcoidal pattern can still be granuloma annulare. So annular elastolytic granuloma, I think for our purposes, this should be grouped with actinic granuloma. And Bernie Ackerman, I personally believe, rightly said several decades ago that these are just granuloma annulare on sun-damaged skin. This has been somewhat controversial. Fortunately, this is very rare. But the idea is you see the granulomatous infiltrate the macrophages, and then you see elastophagocytosis. So here's the sun-damaged fiber that's been engulfed, and you see them in other cells too. So elastophagocytosis is the same. And then just small detail, the entity granuloma multiforme, which I don't think I've ever had anyone ask that in, or put that in a differential. MCAR disease in Africa may also be the same entity. So necrobiosis lipoidica, when I trained, it had the diabeticorum, NLD added to it. And then a number of cases came out showing that it was not as highly associated with diabetes. Just know bilateral shins. So because we're on the lower leg, you can run into this erythema nodosum differential, females more than males, and it's a young person's disease. So one of the concepts here is that you have this layered granulomatous process, almost like a sandwich, that starts up in the superficial dermis and goes all the way into the subcutis. So that's one of the big distinguishing factors from erythema nodosum, is you tend not to have involvement in the more superficial dermis. Erythema nodosum is predominantly septal, and then it will come up and involve the lower portion, the deep reticular dermis, but tends not to be all the way up. And here you can see this less cellular, maybe palisaded area, but it's this layered look. Just to let you know how these things cross over. I had a resident working with me and got a case like this and showed them all the beautiful features of necrobiosis lipoidica, signed it out, went lower legs, went on my way. And then the clinician called me and told me I grew my. So I no longer believe that this histology is should be trusted. It's this, just like sarcoidosis, has a clinical correlation, and it's not just a histologic diagnosis. Necrobiotic xanthogranuloma, I'm just going to mention it. I have not actually seen cases of this, but it just has, once again, foamy giant cells. You can see them here, and degenerated. So it's degenerated areas with debris, and then the foamy giant cells. It's in older patients, very rare, has many giant cells. I got to say, I don't have experience seeing this. So rheumatoid nodule, also older patients, and this is helpful with the granuloma annulare versus rheumatoid nodule, the blue, red. There is a clinical difference. So rheumatoid nodules occur in older patients. They both, like I said, can be near a joint, so that's often not helpful. But the patients who grow rheumatoid nodules also have arthritis, so you'll get that clinically. And one other difference that Whedon really focuses on is that the rheumatoid nodules that have a life, they form the granuloma, and then as they kind of exist, they start to get more and more sclerotic, fibrotic around it, whereas the granuloma annulare tends to stay more edematous and then resolves and doesn't leave fibrosis. So that's a helpful distinguishing factor. So foreign material, this is a big subject, and just know that foreign material, as I said, can be something exogenous, introduced outside the body, or it can be something from inside the body. Subjects, we could give a whole lecture on vaccine sites, and it's there's many there's a number of items to this. One, you can have foreign material and reaction to that. There's even infections that have been with BCG, where you get a local growth of the live vaccine. Now we have these biologics that have different side effects, and you may have reactions at the site. They are given. Know that the material can, and then there's pseudolymphoma is one of the things that can occur here. I'm a proponent of, if you know it's a vaccine site and you're getting a pseudolymphoma or getting a reaction, and there's likely some foreign material there inducing this, it's not a bad thing to just excise it and be done with it. So we see lots of tattoo reactions, very common to not have a elective tattoo there, and to have a old, I think that needs another O, have old, so it can be old traumatic, even from childhood. We see splinters. I've seen filler reactions and been told the patient has no history of filler and they have to. It's around the lips, and you can see the material. Suture talc. The aluminum chloride used for hemostasis and biopsies leaves the aluminum particles, and they get picked up by macrophages, and they're histologically perfect for leishmania. So you can get like basal cell re-excisions as a consult, where the question from the person reading it says, is there also leishmania here? Ochronosis, chronic ochronosis use, you can get foreign material. And then there are oral reactions. The brophy paste, I think it's used for cleaning teeth. Dental, it can get embedded in the mucosa, and you get a granulomatous oral inflammation. So interstitial granulomatous dermatitis, this is a confusing subject also, but it's changed names over time, and I think this is where we've landed. It's not a bad term, but know that it also, look, interstitial granulomatous, it may have some features of granuloma annulare, but there's a really specific clinical. So you have to, I think it's best to stick with this clinical presentation. Ropey cords on the lateral trunk is the clinical presentation. It's probably an immune complex deposition process. And so there's many causes that produce this: collagen vascular disease, neoplasms, others. And because there's immune complex deposition, the patients almost always have arthralgias. So perhaps the interstitial granulomatous drug are very similar, and perhaps the interstitial or incomplete granuloma annulare overlap. These do have neutrophils and eosinophils in variable amounts. So that is, we know that the incomplete or interstitial GA has eosinophils. Generally don't see newts, but you can see debris. So that's one thing to look for. Whedon talks about the histiocytes surrounding blue-hued collagen, stained with a blue hue. I can't say I have any experience and can attest whether this is true or not. So other things for boards, just know that there are granulomatous dermatitis and immunodeficiency disorders. Probably the answer on a board exam is all of the above. No, but you know these patients are immunosuppressed, and you have to rule out infection at the same time. I don't have very much experience with this, and Whedon doesn't actually say very much. Whedon has a short section on granulomatous lichenoid and says that this is a non-specific histologic pattern that can have multiple etiologies. And he lists hepatobiliary, rheumatoid arthritis, Crohn's, infections, and drugs. The drugs he lists for this pattern: ACE inhibitors, allopurinol, antihistamines, atenolol, cimetidine, diclofenac, and erythropoietin. But know that with what we seem to be seeing in our practice is generally secondary syphilis with this pattern. And the clue for that, and so he does have the infection here, so secondary syphilis falls in this. Essentially always they have plasma cells. So plasma cells are helpful, and the immuno for the spirochetes works really, really well. I couldn't find an example, though I know I've read them in our archive. I've read a couple of these, but it must have been longer ago than I thought. But mid-dermal elastolysis, it's good to know about. It's younger women who go to tanning booths and they end up with a rash. The biopsy, it has a life, so there's an active inflammatory moment, and then it becomes chronic and inactive. But what you see are histiocytes that are gobbling up elastophagocytosis, the elastin fibers. So you can see it on the H&E, but an elastin stain can also be used. While it's active, lymphocytes will also be there, and then as you becomes inactive, you don't see the lymphocytes anymore. But this is very good. It's mid-dermal. It really does sit right there where the elastic fibers are, and it's in the superficial to mid-reticular dermis. Rheumatoid fever nodules are rare now, but they are definitely something that could show up. So that's the summary of this non-infectious granulomatous process. If you have any questions, you can email me, and we'll have some good unknowns when we we'll have that session later in the month. So thank you very much. I hope this is helpful, and have a good November.